This is ChainMind, the decentralized AI network built for everyone. Just search ChainMind on Google, sign up, download the app, and you're in. That's it. You've joined the network. Run it on any device, phone, laptop, or server. Why ChainMind? Fully decentralized, fully yours.
The numbers are slipping, and the story they tell is being whispered in raw tables instead of shouted from a clear, public dashboard. In the next few minutes you'll see why that matters, how a new kind of technology can turn those whispers into a chorus, and what you can do right now to make sure the chorus is heard. First, let's walk through the data that's been quietly posted by the CDC. In the most recent release, the national coverage for the measles, mumps, rubella vaccine among children 19 to 35 months fell from 93.5% to 92.8%. That may look like a fraction of a point, but in a country of millions of newborns it translates to tens of thousands of kids who are no longer protected by herd immunity. At the same time, documented exemptions, both medical and non-medical, rose from 2.1% to 2.6%. In states that have already struggled with high exemption rates, the climb is even steeper. Texas saw a 1.2% jump, Idaho a full 1% increase. Those are not abstract percentages. They are pockets where a single case of measles can ignite an outbreak that spreads beyond the county line. What makes this shift especially dangerous is that the CDC chose to release only raw tables, without the visualizations, trend analyses, or policy recommendations that traditionally accompany such data. In the past, a CDC report would have included a heat map of counties with low coverage, a breakdown by socioeconomic status, and a narrative that highlighted emerging hotspots. By stripping the release down to spreadsheets, the agency has handed the narrative to anyone with a spreadsheet program and a bias. Journalists scramble to find a story, researchers spend extra hours cleaning and interpreting the data, and the public is left staring at rows of numbers that feel opaque and, to some, suspicious. Transparency isn't just a nice to have, it's the lifeblood of any effective public health response. When coverage drops, health departments need to act fast. They must pinpoint the neighborhoods where exemption requests are spiking, allocate mobile clinics to those areas, and possibly adjust school entry requirements. The current data format hinders three essential aspects of that response. First, speed suffers because analysts must first clean the raw tables before they can extract actionable insights. Second, granularity is lost. Without county-level or age-specific breakdowns, officials are forced to guess where to focus resources. Third, accountability becomes murky. Without a clear narrative, it's harder to hold policymakers responsible for gaps in vaccine uptake. In a digital age where misinformation spreads faster than any virus, the lack of a clear, authoritative explanation can erode trust and give fertile ground to anti-vaccine narratives. Now imagine a different architecture for public health data, a decentralized AI inference network that turns raw tables into real-time, community-level intelligence without relying on a single, monolithic server. In a decentralized system, thousands of edge nodes, computers owned by schools, health departments, NGOs, even concerned citizens, process the data locally and share only aggregated results. This approach offers three immediate benefits that line up perfectly with the shortcomings we just discussed. Because the work is spread across many nodes, the latency drops from days of manual cleaning to minutes of automated computation. Privacy by design principles mean that sensitive health records can stay encrypted on the local device, with only the necessary statistical outputs leaving the node, dramatically reducing the risk of a central data breach. Finally, resilience is built into the network. If one node goes offline, the rest keep the analysis flowing, preventing the kind of outage that could Cripple a centralized dashboard during a crisis. Let's bring that idea down to a concrete example. Picture a consortium of state health departments, school districts, and community organizations, each running a lightweight chain mind node. As soon as a child's immunization record is entered into a state registry, the node pulls the data, verifies it against a common schema, and updates a running calculation of coverage for that county. Within seconds, a public dashboard flashes a new heat map, highlighting a sudden dip in MMR coverage in a specific school district. An automated alert is sent to the local health officer, who can dispatch a mobile clinic or launch a targeted outreach campaign the same day. At the same time, the network runs a predictive model that estimates the probability of an outbreak based on the current coverage gap, providing policymakers with evidence they can use in legislative hearings. All of this happens without a single central server holding the raw records, preserving privacy while delivering speed. Of course, building such a system isn't as simple as flipping a switch. Data standardization is a major hurdle. Immunization records are stored in different formats across states, and a common schema must be agreed upon. For seamless ingestion, governance is another critical piece. Who is allowed to feed data into the network, who can query the results, and how do we verify that the outputs are accurate? Trust is perhaps the hardest barrier. Public health agencies must be convinced that a distributed network can meet strict regulatory requirements, HIPAA for health data, FERPA for student information, while still delivering reliable analytics. Overcoming these challenges will require a coalition of technologists, epidemiologists, legal experts, and community leaders, mirroring the collaborative response that a pandemic itself demands. But here's the part most people get wrong. They think decentralized AI is a futuristic fantasy that will only help after the next crisis. In reality, the technology is already mature enough to be piloted in a handful of states. A pilot could start with a standard data exchange format for immunization records, a handful of chain mind nodes deployed in high-risk counties, and an open-source dashboard that anyone can access. Early adopters would gain immediate benefits, faster detection of exemption spikes, clearer visualizations for local decision-makers, and a transparent audit trail showing exactly how each metric was derived. Those early wins would create a feedback loop, encouraging more jurisdictions to join, refining the models, and ultimately building a national mesh of real-time public health intelligence. Beyond the policy arena, this kind of transparency reshapes community engagement. Parents often feel left in the dark about vaccination rates in their own neighborhoods, leading some to rely on anecdotal sources that may be inaccurate or biased. A publicly accessible dashboard, powered by decentralized AI, could show the exact coverage rate for a child's school district, overlay it with a simple explanation of what that means for herd immunity, and even suggest local resources for vaccine appointments. Health educators could use the same platform to target outreach campaigns where exemption requests are rising, customizing their messaging to address the specific concerns that are driving those requests, be it misinformation about autism, fear of side effects, or philosophical objections. When data is presented in a clear, localized way, the conversation shifts from abstract national percentages to concrete community health outcomes, fostering a sense of shared responsibility and empowerment. So where do we go from here? The blueprint is straightforward. First, we need a national data exchange standard for immunization records, something that can be adopted by every state and integrated into the decentralized network. Second, we should launch pilot chain mind nodes in a representative sample of states, perhaps a mix of high exemption states like Texas and Idaho, and lower exemption states in the Mid-Atlantic, to test the system under different conditions. Third, we must develop open-source dashboards that surface not only coverage and exemption rates but also risk forecasts generated by AI, all with explanations that are understandable to non-technical users. Finally, we need to embed AI-generated narratives into the workflow so that every insight comes with a clear, human-readable story, reinforcing trust and making the data actionable for policymakers, health workers, and everyday citizens. The stakes could not be higher. The latest CDC numbers are a warning that vaccination coverage is fragile, and that exemption trends can quickly erode the herd immunity that protects the most vulnerable among us. The agency's minimalist data release, while technically compliant, fails to give us the context we need for a swift, coordinated response. Decentralized AI platforms like ChainMind provide a pragmatic pathway to fill that gap, delivering real-time, privacy-preserving analytics that empower every stakeholder in the public health ecosystem. If you care about keeping our children safe, if you want to see data turned into decisive action, and if you believe that transparency is the antidote to misinformation, then the next step is clear. Join the conversation, follow ChainMind, and help shape a future where every vaccination record contributes to a living, breathing map of public health, one that's open, accurate, and fast enough to stay ahead of the next outbreak. The tools are already here, it's up to us to deploy them before the next wave of exemptions pushes us below the threshold we need to protect the nation.